All right, so it's about 7 o'clock right now. So I'm Winston Gwathmey from UVA Orthopedics, kind of help run the conference program here. I've gotten pretty accustomed to Zoom. I just want to say thank you and welcome for our first visiting professor of 2020. We're in the virtual phase right now, but we obviously, when we talked to our chief residents, everybody wanted Dr. Robin West to come down and join us. So I'll help moderate the session, but I'm going to turn it over to Dr. Chaba here in a second. If you have questions, you can use the chat feature at the bottom, or also you can feel welcome to unmute yourself and just ask the question. I'll try to keep things as organized as possible. So Dr. West has two talks today, and we'll take some time between the two talks to have some questions. But in the meantime, I'd like to turn the program over to Dr. Chabra as the chair of the department to go ahead and get things started. So Dr. Chabra.
Thanks, Winston. Good morning, everyone, and welcome to our residents, fellows, staff members, faculty, of course, our alumni, and many of our community members. This is the first visiting professor of the 2020-21 academic year. It's obviously very different than what we've done in the past, but thanks to Winston Gwathmey, we're making the best of it. He's done a tremendous job in terms of arranging our educational curriculum these last 5 months and into this year. So we have a very exciting visiting professor this morning, a close friend to our department, and someone that I think everyone knows already, but we'll get to meet in person for the first time, many of you. So I'll let Dave Diduck, our Chief of Sports, make the formal introduction. But thank you, everyone, for participating this morning.
Thank you, Bobby, and thank you, Winston, for all your organizational efforts. You really are amazing at getting this all together. So Robin, welcome. Thank you for joining us. Thank you for flexibility. Just want to introduce Robin West. She did her college at Johns Hopkins. She did her medical school and residency at George Washington, and then went to Pittsburgh for her fellowship in sports medicine, where they invited her to stay on faculty for the next 12 years. She helped with the Pittsburgh Steelers then, and then came down to Washington to head up sports medicine at Inova Fairfax, which is a very large orthopedic provider, really healthcare facility there, the largest orthopedic provider in the DC area. Robin also now is the head of the musculoskeletal service line, so she has tremendous responsibilities. But it goes beyond that. Robin is really a key thought leader in the world of sports medicine, a true leader in the field, and you really can't give anybody a greater compliment than to say she has become a tremendous role model for female orthopedic surgeons in this country. I hear it all the time from our residents and fellows as they come through. They say, wow, if I could be like Robin West, which is an amazing compliment. So we really thank you for taking your time. You know, often we say, well, thanks for taking time out of your busy schedule, but I just want people to digest for a minute that Robin is the head team physician for the football team in Washington, formerly known as the Redskins, and the head team physician for the baseball team, the Washington Nationals, which are going on simultaneously. So just think about that for a minute. And we really are thankful for her to take the time out to share some this morning. We have two very different talks. We're going to learn a lot, I think, about Robin as a person and her life journey with the first talk. And then we're going to really dive into some science with ACL and learn from her knowledge there. So Robin, thank you for joining us, and we appreciate your time.
Thanks so much for having me. Should I share my screen with
you? Yeah,
you?
go ahead, Robin, if you want to share your screen, and then the floor will be yours. Perfect.
Does that work? Can you guys see that?
Looks great. Yep, thanks.
Okay, terrific. So thanks so much for having me. I was asked to give two talks. So my first talk is more of a personal talk, just sort of about my journey, and then my second topic will be a little more scientific. So I just want to thank you so much. It's really an honor to participate in this. You know, all the trainees that are out there, you guys are so lucky to train under such amazing faculty. I can tell you that all of our, I mean, when I'm on the interview trail and hearing the residents on the interview trail and the fellows, that everyone speaks so highly of your program. So thank you again. Wow, 2020 has been such a sad year. This quote from Leslie Dwight really sums it up. What if 2020 isn't canceled? A year that has been so uncomfortable, so painful, so scary, so raw, that it finally forces us to grow. A year that screams so loud, finally awakening us from our ignorant slumber. A year we finally accept the need for change, declare change, work for change, become the change. A year we finally band together instead of pushing each other further apart. 2020 isn't canceled, but rather the most important year of them all. We have seen dramatic changes in every aspect of our lives. We've watched many people step up to the plate in our country's time of need. Our colleagues have reached far outside their comfort zones to care for sick patients. However, we've also seen extensive financial destruction. Our friends and colleagues have taken large salary pay cuts, been furloughed, or have had to shut their businesses. And the tremendous impacts will be long-lasting and will result in a new normal. In my role as the president of the Musculoskeletal Service Line at Inova, it's been my job to build a top-tier program to provide exceptional care to our patients, grow our clinical volumes, and maximize our revenue across all 5 hospitals to include over 200 orthopedic surgeons. Obviously, during this pandemic, my role has drastically changed. I've had to make some tough financial decisions that truly affect my team members' well-being. I've been managing a lot of fear and anxiety amongst my team while trying to keep them uplifted. It may not be comfortable, but I'm trying to find the silver lining every day. Speaking of stepping out of one's comfort zone, I'll do that now. You know, when Dr. Dudek initially asked me to speak, he asked me to talk about 2 topics and then asked me to share my story. I'd much rather give you a presentation about research or surgical techniques, but now I'll talk to you about my journey to where I am today. We've all had incredible challenges and successes. I'm not here to tell you that I'm different than any of you. I just wanted to share some things with you that I've learned along the way so that I can hopefully help to inspire you to achieve your personal goals. I've been an NFL team physician for 18 years, but my personal and professional lessons culminated during an NFL game 2 years ago. Let's go back to that day. It was a crisp, overcast fall day, November 18th, 2018. It was NFL week number 11. We had a home game against the Texans. It was a typical game day. I got to the stadium around 9:30 for our 1 p.m. kickoff. We went through the standard pregame routine, checking in with the players, our medical meeting, our warm-ups, etc. We had a rough start to the game. Our Pro Bowl quarterback, Alex Smith, was intercepted twice, with one of the picks leading to a 100-yard touchdown return to give Houston a 17-7 advantage. Then with 7:46 left in the third quarter, on a 3rd and 9, Alex was blitzed and sacked by J.J. Watt and Kareem Jackson at the 42-yard line. I happened to be standing there right at the 40-yard line when I saw Alex on the field writhing in pain. So I ran on the field like I do for all other injuries, with a series of thoughts rushing through my head. What will I see when I get there? All those feelings are typical, that trepidation, that adrenaline, and then that eerie calmness. And I get out there, and it's immediately apparent that Alex has suffered a severe right leg injury. His leg is angulated and rotationally deformed.
Alex Smith is down. They came with the blitz. Nobody blocked him up to the front side. This is what happened to Alex Smith. We'll be back.
So I straighten his leg out and I call for the vacuum splint, the car, and the paramedics. I get Alex into our medical room, get x-rays, and cut off his pants. It's at that moment that I realize that he has an open spiral tibia fracture that extends from his pilon all the way to his plateau. He is taken straight to our trauma hospital for an immediate CT scan and then to the operating room. His wife goes in the ambulance and I'm close behind in my car. As I look back on that day and the ensuing weeks, the months, and the past 2 years, I realized that it was the lessons that I learned early on in my life and throughout my education that helped me to get Alex the best care possible. The experiences in education also gave me the strength to survive the months of sleepless nights, uncertainty, and media onslaught. There's takeaway points that I want to stress today. These apply to each and every one of us, no matter if we're a healthcare provider, a business leader, or a teacher. Life begins at the end of your comfort zone. When life throws you a curveball, grab a bat and swing. It's not the destination, it's the journey. Humility, it takes a village to take care of a team. Communication, you've got to pick up the phone. It's lonely at the top and everyone turns to you for direction and advice. And where do you go for guidance? One of the questions that I perpetually get asked is what it's like to be a woman in your role in the NFL and Major League Baseball. I hate to disappoint with my answer, I never prioritized my gender, so it doesn't feel like anything but hard, honest work. That's all I've ever known. My mom was a working professional and a single mother. I was your typical latchkey kid growing up in Southern California. She worked a lot and always joked around that you raised yourself well. But I was lucky in that she provided well for me and taught me from an early age that strong work ethic, integrity, dependability, and humility are the keys to success. My mom taught me to get comfortable being uncomfortable, which I credit for getting me to where I am today. I was always athletic, but I didn't have the opportunity to play on a team because my mom was working so much and couldn't drive me back and forth to practices. So when I started high school, I decided to heed her advice and step out of my comfort zone. I decided to try out for the swim team. Now this was in Southern California, a mile from the beach, where most kids on the team had competed their entire lives. I had not had that opportunity. I was on my own. I was afraid of failure, but I also wanted to be part of this team. So the summer before high school, I trained hard and devoted myself to making the team. The hard work paid off. I wound up winning MVP that year, and by my senior year, I was co-captain of the team and competed in the California State Finals as the anchor of my relay team. Stepping out of my comfort zone challenged me and opened the window of possibilities. I continued my swimming career at Johns Hopkins University. I still remember walking across the campus in the dark and snow to practice at 5:30 in the morning. That was a lot different than swimming in Southern California, but I still loved it. Unfortunately, I ended up getting mononucleosis that year. My spleen had enlarged, and as a result of the virus, I was no longer cleared to swim. So I had to make a decision. Either I could sulk or I could pivot. And I chose the latter, even though it hurt me to let my dream go. I still wanted to compete, but I couldn't play sports anymore that season. So I decided to work in the training room as a student athletic trainer. I worked 20 hours a week with the football, men's lacrosse, and women's basketball teams. I worked directly with the athletes, the athletic trainers, and the team physicians. I even got to watch surgeries on players. You might be wondering why I'm telling you all this. The reason I share it is because I believe 1,000% that we learn the most and build our confidence by getting out of our comfort zones. Also, when life throws you a curveball, grab a bat and swing. You may hit it out of the park. Those were my first experiences working as part of a medical team, and they solidified my interest in sports medicine. I wanted to be an orthopedic surgeon. Had I not chosen to pivot to working in the training room after getting mononucleosis, I never would have fallen in love with orthopedic surgery. And I certainly would not be where I am today. Following college, I went to medical school at George Washington University. And I was fortunate enough to meet Dr. Neviser, who was my first orthopedic mentor. He believed in my skills and my ambition and always supported my goals, despite my gender. He ruled with an iron fist and demanded perfection. His leadership fit my work ethic perfectly. I stayed at GW for internship and residency, and then I went to the University of Pittsburgh for fellowship. It was there that I met my next set of mentors. Dr. Freddie Fu taught me how to be an integral part of the athletic training team. He taught me the importance of communication with the athletes, the coaches, athletic trainers, and families. He taught me to be available 24/7 and expected all of us to answer our phones immediately. And if any of you know him, he would routinely test us with that 3 or 4 a.m. phone call. Dr. Fu also taught me to learn all the new tools and methods in orthopedics, but not to jump on the bandwagon too quickly. He taught me to let science guide my decision-making in the clinic and operating room. Innovations in medicine are not always better. Dr. Jim Bradley was another mentor to me. He taught me about how to take care of elite athletes. He told me to really get to know their sport, their position on the field or on the court, and to talk to them with confidence and clarity. He taught me that orthopedics is an ever-changing field. I needed to be constantly learning to stay at the top of the quick-paced advancements in sports medicine and orthopedics. Dr. Fu asked me to stay on as a faculty member and as a team physician at the University of Pittsburgh. And then Dr. Bradley asked me to serve as his assistant team physician for the Pittsburgh Steelers. This opportunity was a pivotal moment in my career. At first, I was sure if I wanted to do it. I had some other great job offers that I was considering as well. But after a lot of thought and my husband's convincing, who is from Central Pennsylvania and a huge Steelers fan, I decided to lean in and take a chance on this opportunity. That decision opened many doors for me along my career path. Opportunities like this come at a crossroads of hard work, integrity, and timing. They don't come often, so when they do, you've got to be prepared. There's this quote that I really identify with. Luck is what happens when preparation meets opportunity. I know that I wouldn't, if I wasn't so determined and willing to step outside of my comfort zone and swing at those curveballs, I would never be so lucky to be where I am today. Let's fast forward now 12 years. Another opportunity arose for me to come and build a sports medicine program at Inova in Northern Virginia. I was not looking for a job. I was very happy with my position at UPMC, and this move was risky. Not only would I have to build my own practice, but I have to develop and grow a new program. And if it wasn't successful, it would be my fault. I had been recruited by other academic programs and private practices over the prior years, but this opportunity was something really enticing to me. I believe in taking calculated risks that will challenge me. This opportunity was too desirable to pass up. Dr. Bradley tried to convince me to stay at UPMC. He promised me that I would be the queen if I stayed in Pittsburgh, and I told him I had the chance to be the king in Virginia, so I seized this opportunity. With lots of hard work and the support of ANOVA, I was able to put together a phenomenal sports medicine group, really from ground zero. We built this group of orthopedic surgeons, primary care sports medicine physicians, athletic trainers, physical therapists, a neuropsychologist, PhD researcher. I had the opportunity to build something from the ground up and hand select my team. I believe that leaders are not great because of their strength, but because they empower others. Within my first year at ANOVA, I was recruited by the Washington Redskins, or the football team, and the Washington Nationals to serve as their head team physician. Both teams were intrigued with our developing comprehensive sports medicine program, and they were looking for the same foundation for their medical teams. Even though many people consider taking care of a professional team to be the pinnacle of our profession, there are still a lot of things to consider before accepting these roles. There's a lot of potential liability with the position, and the time commitment is tremendous and certainly not efficient. Plus, there are a lot of politics, especially in DC. Before signing the contracts with the team, I met numerous times with the GMs and the owners to explain my vision of an integrated sports medicine program. Several of my colleagues had told me their extremely involved owners and GMs had micromanaged the medical care. I wanted the Nationals and the football team to understand the medical team is responsible for making medical decisions. My main concern was being the head team physician for not one, but two teams. Could I really take on both jobs simultaneously? I was already inundated with trying to build a sports medicine program at ANOVA. However, I decided with good planning, many sacrifices, and the help of my tremendous partners and supportive family, both jobs were doable. So I accepted the positions. I'll be honest with you, it was much tougher than I thought it would be. They brought me in to revamp things, but I had to work with medical staff who had established long-term relationships and processes that they didn't want to change. I had to work closely with them to integrate new policies and procedures. I also brought in some new medical team members. I have certainly been tested before, especially as a female orthopedic surgeon being trained over 20 years ago by some old school surgeons with varying views of women. I remember my very first day scrubbing into an orthopedic case as a third-year medical student. The orthopedic chairman at the hospital told me that I needed to wear small scrubs to show off my nice tits. However, these comments really never fazed me. I've heard lots of comments, dirty jokes, but my skills were never questioned. However, when I came into the NFL as a new head team position, I certainly ruffled some feathers with some well-established staff. So they tried to undermine me a little bit. During training camp, one of them introduced me to the entire team as a new head team position who was hired for good looks. Another one grabbed me during a preseason game and told me I was not selected to be the head team position because of my experience and skill, but rather I was selected as a pretty token team position. I felt like a leader with no real power. Wow, after all those years, I was finally insulted. I am relatively easygoing, but that comment on the field cut me to the bone. I almost walked off the field. But I decided to fight the comments head on with integrity and strong work ethic, like I had always done. Interestingly, by the end of the year, I felt like I had a great relationship with the entire team and of players in the medical team. I routinely had players pull me aside and they were complimenting us for the great care that we were providing them. And they were happy with all the new changes. I had another setback that year. I was looking forward, this is my first year, I was looking forward to the home opener between the Redskins at the time and then the Steelers, my previous team. It was Monday Night Football. No matter how many times I experience it, nothing beats that feeling I get on game day. The adrenaline, the noise, the smells, the trepidation. It's always a big rush, the fans, the cheers, all of it. And it was the first game between my new team and my old team since I accepted my new role. I knew how hard both teams had worked in the months leading up to that day. I had also been training during my personal time. I was either outside road running or cycling every day. I had recently competed in the Ironman 70.3. The day before the game, before the sun came up that morning, I put on my helmet and set off for an early morning road ride. I zipped along the quiet, windy country roads and felt the crisp fall air blowing on my face. It was so peaceful as I rode into the sunrise. But then it happened. I was speeding down a hill when a groundhog stumbled out of the shadows of a tree right in front of my bike and boom. I couldn't dodge it if I wanted to. It all happened so fast. That grimy rodent made me somersault off my bike and tumble onto the cold concrete, and I blacked out, and there was no one around. My GPS tracked the entire ride. You can see it here. I laid in the middle of the road for 5 minutes. I was unconscious. I had no idea where I was or how I got in there when I woke up. I remember waking up and seeing blood on the pavement. My bike was strewn across the road and my helmet was shifted to the side of my head. I was laying in the middle of the road, staring straight up this hill. I remember seeing the center white dotted line under my sweaty, scraped cheek. I dragged my bike off the road. My arm dangled at my side. My head throbbed and my chest was crunching with each breath that I took. The early morning sunlight hurt my eyes. At some point, I came to enough to find my phone in my back pocket. And I called my husband and told him that I had no idea where I was or how I'd gotten there. Needless to say, he panicked. My Find My Phone app was not set up, and my brain started to finally function, and I figured out that I could text my husband a Google screen map shot of my location, which you can see here. My trauma partners, so he and my daughters rushed to pick me up and bring me to the trauma hospital, where I was diagnosed with this 4-part proximal humerus fracture, multiple rib fractures, and a severe concussion. I had surgery on my shoulder that afternoon. My trauma partners did an awesome job fixing it. However, this operation failed. It devastated me because I had 16 screws and 2 metal plates in my arm, and this whole thing fell apart. I couldn't blame anyone else but myself. I had not been a compliant patient. I was back in the training room 2 days after surgery, trying to examine these huge football players with my arm in a sling. I went back for revision surgery 2 weeks later as my tuberosities had displaced. And then 8 months later, I had an open license of adhesions and hardware removal. I've had to adjust this to limited mobility, pain, and weakness, and this accident changed my life. It brought me back down to earth because I started to think that I was invincible. I thought that I had reached the pinnacle of my career. I thought I really had it all, a great family and a job that I loved. But the 8-inch scar left is a daily reminder of how fragile life is. It's nature's own tattoo to keep my enthusiasm in check. I thought that I was tough and that nothing could break me. However, as the saying goes, we are more vulnerable than we thought, but we are stronger than we ever imagined. I learned to delegate and accept help from my family, my partners, and my great team of athletic trainers, physical therapists, and sports psychologists that I'm blessed to work with. I learned the importance of building resilient communities and organizations. There are times to lean in, and there are times to lean on. Speaking of humility, it extends beyond my personal life and deep into my career, as it really takes a village to care for elite athletes. You're an integral part of the team, but certainly not the most valuable. The athletic trainers and coaches usually know a lot more about the players than you do. I rely on them because it's not easy to witness every injury during an NFL game. It's noisy, fast-paced, and crowded. I listen to the players, the coaches, and the athletic trainers. They may witness an injury or notice a player is acting differently before I do. I certainly love what I do, but it's not all glam and glory. I get a lot of emails and letters from people look up to me or who admire my job. They see me as a first female head team position in the NFL and Major League Baseball, as well as my role as a president of the musculoskeletal service line. Spectators see me on the fields of games, but don't understand all the sacrifices and hard work it took to get here. I'm under constant scrutiny, and it's not always easy. News outlets constantly criticize team doctors for poor decision-making and attribute it to our allegiance to the team and not to the player. The media has no idea what it's like to be in the heat of the game, having to make a quick yet thoughtful decision amongst all the noise, bright lights, and pressure to win. Sure, it's always great to win, but my number one priority is always the player's well-being. As a team physician, you will go from being players and coaches' best friends to their worst enemies. Oftentimes, you will need to make decisions that may have a huge impact on the team. A recent tough decision that I made was during the World Series this year. Our 3-time Cy Young winning pitcher, Max Scherzer, called me on Saturday morning of Game 4 of the World Series. He woke up with severe periscapular pain and was due to pitch in Game 5. He wanted a quick fix for what he knew was related to a large degenerative herniated disc. We had 24 hours to get him ready to pitch. I collaborated with our athletic trainers and physical therapists, and we decided to try a trigger point injection as a quick, safe fix. He had immediate relief, but woke up the next morning in writhing pain and was unable to lift his arm. He was fuming, he was disappointed and extremely frustrated. He obviously could not pitch in Game 5. The team was let down, and Max questioned my judgment. I arranged for our pain management physician to do a foraminal injection to try and get him ready for Game 7 if necessary. We flew to Houston after the game, and Max gradually started to feel better. On Tuesday, the day of Game 6, He tried to throw, but he was still unable to do so. He was enraged at this point. If you know him, he pinned me in a corner and told me that I clearly made a mistake. He wanted me to apologize to him. He felt like the trigger point and the foraminal injections were not working and probably made him worse. It was game 6 and game 7 was a day away and a very far reach. He felt like the weight of his entire series was on his shoulders. And if you know Max, he was like a caged animal at this point. He was pacing and hissing, spitting. His teammates stayed clear of him. I held my ground on our recommended treatment plan, especially on such a tight timeline. Magically, with an additional rehab, chiropractic work, and his incredible mental fortitude, he woke up in the morning of game 7 and he was ready to pitch. Scherzer pitched the first 5 innings in our 6-2 victory against the Astros, allowing 2 runs in a grinding, gutsy effort that will now go down in World Series lore. Max didn't win the game, but he kept the Nationals close, allowing our offense to make the late game comeback as it scored 6 runs in the final innings. On the field after the win, Max was exuberant, and he gave me multiple bear hugs and thanked me profusely for helping him to get to this point. The pitching coach declared that it was my treatment that helped him to win the series. I told you this story to reiterate the importance of teamwork and communication. You can't always be friends with the players and coaches. You have to separate the injury out from the situation and use your best judgment. I clearly played a minuscule part in this comeback, and I did not get discouraged when he challenged me. I listened to him, I collaborated with our team, and together we were all able to contribute to the win. As a team physician, we all have stories like this, whether you take care of a high school, a collegiate, or professional team. Sometimes the stage is just a little bit bigger. 3 Super Bowl wins, a World Series, Big East tournaments. I've been lucky to be part of many high-profile games. There have been noteworthy wins and losses on the big stage. With millions of spectators in the stands and TV, my adrenaline is certainly pumping. But as long as I keep the best interests of the players in mind, I'll never have a moral conflict. To be successful in this fast-paced, multi-million-dollar environment, you need excellent communication skills and full-time accessibility. I'm available 24/7 to the athletes, the athletic trainers, the GMs, and the agents. My phone rings frequently and the texts are constant. The players typically view us as their everything physician. They call with questions about their kids, their spouses, eye and ear issues. You have to be the doctor of all trades when taking care of a team. Many people ask me how the players treat me as a woman. Honestly, I don't think that I'm treated any differently than my male colleagues. Most of the players have been raised by single moms or grandmothers who worked hard to provide for them. So many players are more open, honest, and respectful with me than they are of my male counterparts. Here I am on the sidelines with Dr. Bradley when I was 9 months pregnant. This was a few days before my baby was born. The picture below is of James Harrison holding my 5-day-old baby in the training room. Trying to dodge the players and the ball is a little trickier when you're pregnant. I've hidden in closets and bathrooms and training rooms and pumped milk after my babies were born. I've pumped milk in between surgeries. I even pumped at halftime during Super Bowl 40. I had a miscarriage on the sideline during an NFL game, but had to keep working as though nothing happened. I often hide in the corner of the team's locker room to change into my game time gear because there are no women's locker rooms or bathrooms in these stadiums. I've literally been caught with my pants down several times. I guess that these are experiences men have never had. Let's transition back to life-changing events. For the great satisfaction that I get from my job, being a mother has been the highlight of my life. I've always envisioned myself as a working mom, but motherhood hit me really hard. I never knew how strong these heartstrings could be. Being a working mom is certainly not easy. I felt guilty when I wasn't home and felt guilty when I was at work. I hated leaving when they were sleeping and coming home when they were asleep. Society puts extra pressure on women. They expect women to work like they don't have children and to raise children as if they don't work. My 8-year-old daughter, who's now 13, finally made me appreciate my working mom predicament. She's a baby of the family and always wanted me around. One day I asked her if she wanted me to quit work to spend more time with her. She thoughtfully said, "Mom, you love your work. And if you love it, it makes you happy, which makes me happy." Research has shown that success and likability are positively correlated for men and negatively correlated for women. This means that as men get more successful, both men and women like them better. But as women get more successful, everyone likes them less. I recently found out that I have 2 nicknames with the athletic trainer, Dr. Westy and HBIC. I had no idea what HBIC was, so I looked it up, and it means head bitch in charge. They told me that they call me that because I get shit done and I'm no nonsense. I guess that I'll take that as a compliment. It's better than being called passive or lazy, but it does confer a feeling of loneliness at the top. And I'm one of the only ones doing it, and it's not always easy. Let's get back to Alex. All these life-changing lessons culminated with his injury. I had to assemble a top-tier medical team to provide the care that he needed. My orthopedic trauma partners played a key role, but then Alex got necrotizing fasciitis that required extensive debridements, a gastrocnemius rotational flap, a vastus lateralis free flap, a frame, a rod, and multifaceted rehabilitation. He spent weeks in the hospital, required 17 surgeries, and almost required an amputation to save his life. I played many roles in his care. Not only did I help to coordinate all of his care, scrubbed on his cases, and was a medical mediator to his family and to his wife's confidant, but I had to bear the burden of the significant injury. My trauma and plastic partners deal with this stuff daily, but we don't see these kind of injuries in elite professional athletes. The media crushed me. I couldn't even turn on the radio on my drive to work without hearing my name being slandered. They criticized the medical care and blamed his infection on me, my team, and my hospital. Little did they know that he had necrotizing fasciitis and was hanging on to life's fragile threads. He had an open, severe tibia fracture on a muddy football field. I wound up reaching out to the Secretary of Defense to get Alex special access to the Center for the Intrepid. We went down there to get their input on his treatment, recovery, and orthotic options. It was a team effort all around. But in the end, it was his wife's and his personal determination and grace that reminded me why I do what I do. It's certainly not glamorous, but the opportunity that we get to provide comprehensive care from amateur to elite athletes is unparalleled.
All right, so position is back, but modification is still weird. And you haven't just going
it's not muted. Anyway, they push us beyond our limits. They challenge us and they keep us at the top of our game. The day before Alex's wife shot this next video, he called me to thank me and the rest of our incredible team for getting him back to what he loved, playing with his kids and being able to compete each day to better himself as a person and a player. This was on his birthday just a few months ago. Try and load it up. I share all this with you today to show that my path wasn't straight. My road to success was a twisty trail with falling rocks that I had to dodge and duck to make it to the finish line. And just when I thought I'd reached the pinnacle, I realized it was a mirage, and this path kept going. I know that I'll never stop stepping out of my comfort zone, that I'll always have to be ready to swing at curveballs, that no matter what, slowing down to appreciate the wins and losses is necessary to keep perspective and not miss out on the journey. I'm committed to exercising humility regardless of how high I climb. And I know that communication with the teams that we built will be the key to keeping everything moving in the right direction. I encourage you to stop more often and tell your family that you love them. We're all picking up pieces after the pandemic. Tell your colleagues that you're grateful for the dedication and hard work. Thank your OR staff. Appreciate your team of athletic trainers, physical therapists, strength and conditioning coaches, and other medical team members. None of this would be possible without each and every one of them. Thank you.
Thank you, Dr. West. That was awesome. Really awesome. Truly phenomenal, says Bobby. Dr. Park asks how the trauma community responded to the primary ORIF, and was that considered when releasing the documentary?
Yeah, they were, they felt like it was the right thing to do. And, you know, the wound itself actually was small. It was less than a centimeter. It was a tiny little pinprick. Obviously, the soft tissue injury was extensive. So we did a little percutaneous plating because of the extensive, you know, went through the peel on up to the plateau. So having intra-articular on both sides, we didn't really have a lot of options except for doing a frame that would span his foot all the way to his thigh. And so by doing these perc plates, we felt that was the best at the time.
Excellent. Any questions from the audience? I have a couple in the chat, but if anybody has any questions, Dr. Duduk or Dr. Chaub or Dr. Brockmar.
Thank you very much. Absolutely phenomenal presentation. It's really remarkable to see your career. And, you know, we crossed paths in college years ago, but I know I got to learn about you from my brother who trained with you many, many years ago. But I really appreciate the wisdom that you've provided about the struggles you had in your career and the sacrifices you've made. One question I've always wondered is your time, what time part of your career is administrative, what part is caring for the professional athletes, and then what part is just doing surgery on your weekend warriors and active individuals? Because it seems to me that particularly doing football and baseball season, you really don't have much time other than traveling with the team and caring for professional athletes. So how have you balanced all those different demands in addition to being a mom and with your kids?
Obviously, it's tough, it changes throughout the season. So depending on the time of year and stuff, but my number one thing has always been the clinical care. I've always wanted to keep a clinical practice in surgery. So I maintain that I have a full day of clinic and 2 OR days, and that's always been there. And I try and have a day and a half of clinic if I can. That doesn't always work. And then keeping those 2 OR days. In my new role, I just took on this role as musculoskeletal president across the service line. So it's a big role, and they've asked me to be more administrative. I told them when I took the role that I would not be. I think surrounding yourself with great people, a great team. I've got a lot of business administrators I've worked with, so they can run things by me. We can work together where I can help do the clinical stuff, and then they can do the administrative stuff. But again, it's a team effort. With the professional teams, it's tricky. The baseball team, which is great, so we have to cover all the home games for baseball, and I have great colleagues. And so what I can do with my colleagues is that we can rotate games. So we all cover like 20 to 30 games, and we'll rotate those games. I have to be available in case there's an emergency or something, but I don't have to be at every game. Certainly still covering 25 games is a lot of games, and we get rain delays and late games, but and then for football, I have to be at everything. So that's really the most time consuming. I've got to be at training camp. I have to be at home and away games, preseason games, NFL combine. So that's busy, and that's really a job in itself. But again, surrounding yourself with great team, and having great athletic trainers that we work with, who can make a diagnosis and start the process before I get to see them, have the player come to my office to be seen. It takes a lot to put everything together to make it work. My husband jokes around that it's like 5 jobs. It is, but again, I think that I can never do it without the support of my family and the support of my colleagues.
Robin, this is Dave Deduck. Thanks again. That was a tremendous talk. And I've always had tremendous respect for you as an orthopedic surgeon, as a leader in sports medicine, and for all the just amazing things you do, but even more so now after hearing your personal story and getting to know you a little bit better in that regard. There are a lot of people listening that are training. What advice would you share with them about how you balance all these amazing responsibilities and family?
Yeah, again, you have to set your goal, your priorities, and things are going to change. My mom always told me that. My mom was a single mom, and she said that she always put family first. I didn't really think that when she was little, because she was working so much, and I was like, well, she's never home. but I always knew that I was taken care of. I knew that she always would support me. If I needed something, she'd be there. And I wanted my kids growing up to feel that way too, that no matter what, I will be there. And so I think you just have to figure out, and again, that's going to change. When my kids were babies, it's different. Now they're teenagers and they don't really want me around, right? So I think you just have to, it's going to change throughout your career. And in certain times, like I said, right now, in this moment in time, baseball and football are starting. And so I have to prioritize that a little bit. My family understands. My clinic schedule's kind of changed a little bit. I've pack in a day of clinic and 2 OR days and try and squeeze things in around that. But when I'm not in season, I'll change some stuff. I might do a little more clinic and add on and spend more time at home and try and do things. Certainly, I love my time at home with the family and do that as much as I can. But it's ever changing. People say, what's your typical day? There's no typical day. It certainly changes and changes from year to year on what's needed. But you definitely have to have your priorities, I think. We all do, right? That's what we do.
Yeah.
I have a great husband who's very helpful at home too, and I have a great nanny. So those are all. I've never wanted someone to live in the house. I've always had someone who comes in. I didn't want someone to replace me, so I've always made sure that people are available to help if I need them. But I wanted to be the mother taking care of my kids. So.
Mm-hmm.
Great.
So, if no one else has a question, I got a question for you, Robin. I know it's just all over the news and we really can't ignore COVID-19. I'm just curious on your thoughts. What is the stress you've had as you've prepared the Washington football team and the Nationals to, return to play? And what are your concerns now? And as an orthopedic surgeon and the head team physician, who have you had to rely on more so than in the past because of this unusual time in this country and the world?
On the NFL, I actually sit on the board of the NFL Physician Society. So we get to be in on a lot of the meetings and planning for the NFL. So that's been helpful. And then on the baseball side, just as a team physician, just following the protocols. They certainly are very well planned, as well planned as they can be for not being in a bubble, right? We're not really in a bubble, but we're getting tested. And I'm very surprised by how well it's run and how organized. Having a great athletic trainer, a head athletic trainer who's in charge of the infection disease control or whatever for each team has been tremendous, because as long as they run a tight ship with the players, then it seems like a pretty safe environment. Obviously with football, contact sport, but we are getting tested every day. So it gives you a little bit of a false sense of security. We haven't had anyone test positive yet on football. We've had 12 with antibody positive tests. So they were sick at some point, but none of them have felt sick. None of the players actually on baseball and football that I've taken care of who've tested positive for antibodies or for COVID have been sick. So I think the scary thing is that you kind of feel a false sense of security. These guys are healthy, young. They're like, I was positive, but I never was sick. And so it gives you this false sense of security, which I think was what happened in baseball. Guys are feeling good. And then all of a sudden, the Marlins, 19 players get sick. And so that's concerning. But so far, so good. That my main concern, after seeing the testing, we do a whole cardiac workup on our football players. So I was telling these guys last night, we do an echo, troponin levels, and EKGs after a positive COVID test. And one of our players has severe cardiomyopathy, and he was a combine player. So we have his EKG from February, which was normal. So the fact that he developed that without even being sick from COVID, but having COVID antibodies, is certainly concerning. So I think that's my main concern. What's the long-term risk to these healthy young guys?
Dr. West, this might be a tough one, but as a program director and as a program, what can we be doing to appeal to women students to become orthopedic surgeons? Do you have any advice for me as far as how to make this? Because we're always trying to recruit great women into our program. Any advice for that?
I think you already have that reputation. I can tell you that I hear that all the time from women who reach out to me. So I think you guys already have that. I think you have a great group of colleagues. I think just being supportive, and at least for me, I never wanted to be treated differently. I wanted to be treated the same as men. So, and that's what I sought in the programs that I trained at. And I think that's what most people are looking for.
Thanks. Any other questions before we move on to the next talk? Awesome. Well, Dr. West, I guess we'll just keep powering through if that's okay, because I think all of us want to hear about ACL reconstruction. I know Dr. Chhabra does. That's why he's here.
That's right.
I'm at the edge of my seat.
Well, we'll move on. So our next talk will be on ACL reconstruction, how to optimize outcomes after that. So.
All right, let me see if I can pull that one up here. Get the right one. Sorry, give me a second here. I have two screens in my office and I get confused here.
In the meantime, to all the audience, Dr. West, we've sent her up all of our UVA ortho stuff. Normally we have, between the two talks, Dr. Chhabra comes and says thank you, but we've sent up a UVA hat, UVA shirts with the stuff so that she can.
I love them. They're great.
You can support those in the Washington football training room.
But we sent up, most importantly, the best wine from Charlottesville region so she can enjoy it with Mark, her husband, at some point.
Yeah, bottle of Octagon, right? I think, didn't the Queen request that? Or so no, George Bush's daughter had that at her wedding or something like that. So,
Oh, really?
Yeah, it was like a special request of, I think, George Bush or something. It's definitely a famous wine from our region.
Ah, excellent. Can't wait to taste it.
Yep. All right. So thank you, Robin.
Can you guys see this?
Yes.
Okay. So next talk is, can we improve outcomes after ACL reconstruction? Let's see if it's going to work here. No disclosures for this talk. So we know the goal of ACL reconstruction is a functional and anatomical restoration of the ACL, and really in a timely fashion, right? Athletes are on us all the time. How quickly can I play? How quickly can I play? So these are our main goals. We know, overview, the success rates vary in the literature from between 69 to 95%. And what factors determine success? The surgical technique, clearly, obviously, tunnel placement, the graft and implant choice, the biology, the graft healing, the type of graft we're using, any concurrent injuries. The rehabilitation plays a key role. And there's more literature supporting functional training with vestibular and ocular focus, an emphasis on the modifiable risk factors, especially in females, such as quad dominance and valgus alignment. And the brain plays a huge part as far as a psychological response. So when we look at the analysis of failures, this is a MOON study. Chris Kading published in 2011. So this is just looking at the data. And MOON is the Multi-Center Orthopedic Outcomes Network. It was established, I think, in 2002 or 2003. And it's, I think it's 7 hospitals now and 17 surgeons. And they put together their data on ACL reconstruction outcomes. So if we look at allograft versus autograft, this is over, not in the young population, it's over all ages. So you can see there's about a 3 times failure rate with allografts. And you can see that here. And interestingly, if we look at now ages, if you look at younger, under the age of 25, the failure rate can approach almost 25% with allografts, but it diminishes as we get older. And then here's an analysis looking at, again, at age-based and seeing that for all graft choices, allograft and autografts, the same thing. The failure rate is much higher for younger patients. As we get older, the failure rate goes down significantly. This is looking at hamstring and patellar tendon. This is always a question, you know, what is the failure rate? And it's interesting, if you look at those first couple of years, it's a pretty similar failure rate, but as time goes on, time to revision, the failure rate of hamstrings goes up and the patellar tendon stays pretty stagnant. This is another MOON study that was just published back in February of this year in AJSM, and it is an analysis of ACL failures in high school and college athletes, looking at hamstring and patellar tendon. This is ipsilateral on the left and contralateral on the right, and looking at the associations between them. And they took this data, and I'm going to give you an example on the next slide. But what they did on this was they were able to establish a nomogram. This is a nomogram of ipsilateral injury. So I'm going to give you an example. Let's say we have an 18-year-old female soccer player. So by doing this 18-year-old, we go down this line here to age 18, and she gets 50 points for that. She's female, so she'll get 0 points for that. And then we can add up all her points, and her nomogram score comes out to be 135. So down here, total points go to 135. She's got less than a 0.05% or less than a 5% risk of re-tear, just based on that alone. Now, if we pick a graft choice, so let's go now, she undergoes an ACL reconstruction with patellar tendon autograft. So we go to this graft choice, which is down here, BTB and hamstring. If she has a BTB, she gets 0 points. So again, we can come down here with that score that she had before, the 135, and she has less than a 0.5, or less than a 5% risk of an ipsilateral ACL graft tear, so a revision surgery. However, if the same player, let's say we picked a hamstring autograft on her now. So we go to hamstring here and we look and she gets 55 points for that. So now interestingly, she goes from a 6-year risk of an ipsilateral graft re-tear to almost 10% now. So she doubled her risk just by having a hamstring autograft. Sorry, my pointer was on the wrong screen. Anyway, so now we look at return to sports after an ACL reconstruction. So 500, this is a study out of Australia where there are 500 patients who competed in Australian football, basketball, netball, and soccer. And if you look at the return to sport at 12 months, it was pretty low. And you look at about 2/3 of athletes had not returned to full competition by 1 year out. And you can see these numbers, 33% had not attempted, 33% had attempted full participation. And the reasons for this reduced sports participation is typically, the fear of re-injury. So fear plays a huge role. You can see it's almost 20%. This is a systematic review. And if you go through all these different reviews, this is another one out of, this is Ardern, again, out of Australia, looking at 69 studies over 7,500 patients. And again, that return to pre-injury sports is 65% again. You'll keep seeing this across the board. In the NFL, we can look at this study. This was an older study from 2010, AJSM, but looking at 49 athletes after a primary ACL reconstruction. Again, that kind of 63, 65% return to play at almost 11 months out after an ACL reconstruction. Interestingly, what we do see is that the odds ratio favors return to play was 5.5 for players with more experience, more than 4 years of experience, versus a return to play 12.12 for players drafted in the first 4 rounds. So obviously these outcomes favored more experienced and higher ranked players. Now we look at female athletes. This is a study out of Mayo Clinic, and they took 90 soccer players versus 247 non-soccer female athletes. So both athletes, but one playing soccer and one not. And if you look at these overall rates, there's a 23% chance of either a contralateral or ipsilateral graft tear versus an 8.5% chance for the non-soccer. So soccer, there's a significant difference in that. Now we look at, again, return to sport here. So this is NFL running backs and wide receivers. So again, 20% never returned to play in the NFL. Average return to play was a little over a year. And the performance ratings down. So based on power ratings, they were down 33%. So what are the biomechanics? We know the ultimate load to failure of a native ACL is about 2,000 newtons. For a BTB autograft, it's 3,000 newtons. For quad tendon, it's almost, it's like 4,500 newtons. For quad tendon, it's about 2,300 newtons. We go on to the biomechanics after an ACL reconstruction. We know that ACL is subjected to 150 to 500 newtons of force during ADLs and rehabilitation. So these graft choices far exceed the forces of the 150 to 500 newtons. But we also have to consider this: within the first 4 weeks, the graft is exposed to 220,000 loading cycles. So really, where's our fixation weak? The fixation is the weakest link in the postoperative phase. Fixation has a load to failure of only about 500 to 800 newtons. Ideal fixation needs to be strong enough to avoid failure, stiff enough to restore knee stability, and secure enough to avoid slippage. So we can look at healing. How do these grafts heal? There's intratunnel and intra-articular healing. We know the 3 stages. It goes through a graft necrosis, then revascularization, then remodeling and proliferation. And we can start to look at timing. And interestingly, if you look at, even 6 months out, the graft strength is not even at 50% yet. This is a study sort of looking at that, actually. This is an analysis of failure after ACL reconstruction using an allograft. So this is a prospective study over 4 years with 200 patients, and there's a 90% follow-up, a 13% overall failure rate. So this is looking at all ages of patients again. So, but if you look at this, almost half the patients failed before 9 months, and the highest failure rate was between that 6 and 9 month window. So this is something to consider when you're releasing athletes back, that 6 to 9 month window. Again, this is an allograft, but it's that most dangerous time. Patients feel great. They're starting to push themselves, but is the graft mature enough to be ready to withstand the forces? We know the ACL insertional site is a bone ligament transition. There's a unique transitional tissue emphasis, and it aids in efficient load transition between the 2 distinct materials. You have 2 types. You have the direct bone transition, which is how part of the ACL attaches, how Achilles tendon, patellar tendon attach. And then you've got the indirect, which is more like the deltoid attachment and the tibial MCL attachment. And that the indirect is over a broad area via Sharpie's fibers. And we know that graft tunnel healing occurs both ways, through direct and indirect. BTB autografts are going to be more direct, bone-to-bone healing, but soft tissue is both direct and indirect. And we know the allografts also heal that way, but we're just not sure of the time. And you look at the literature, and it typically is showing between 12 and 14 months that it takes an allograft to mature. So we talked about intratunnel healing. Now let's talk about intra-articular healing. What happens during intra-articular healing? The tendon that you put in turns into a ligament. So it's a ligamentization. It's this morphological adaptation of the graft in response to stress. It was described in 1986. And again, it's the biomechanical and the histological changes in the tendon graft as it turns into a ligament. And it follows Wolff's laws, which is in response to the forces placed on it. So when does ligamentization occur? You know, if we look at these are animals and human studies. And if you look at that timeline, when is that maturation happening? It looks like, you know, most of it is happening around that year out. So when we start to think about releasing athletes back, what's too early and when's a good time? How do we improve graft healing? There's so many studies out there. There's so many things, variety of PRP, mesenchymal stem cells, collagen platelet composites, bone marrow concentrate, calcium phosphate cement. List goes on and on. Here's just an example of one of the studies looking at collagen platelet composites. And what they did was they placed these around an allograft at the time of an ACL reconstruction in pigs. And they found there's a reduction in AP laxity, improved graft structural properties, and decreased regions of necrosis. This is a PRP study meta-analysis looking at 32 studies of PRP. You know, it's so variable. The issue with PRP is there's so many different things, or different product types, you know, leukocyte poor versus leukocyte rich, platelet variability day to day in each person. So these studies are variable, but most of the studies did seem to show a decreased donor site morbidity at the patellar tendon autograft site. Graft maturation seemed to have a positive effect on graft maturation. Bone tunnel and graft incorporation, there were variable effects in the literature. And again, we need really more studies to look at clinical outcomes. But here's some MRIs. This is an MRI looking at, you know, with the gel and without the gel. So this is a hamstring graft here. So you can see with gel and without gel, patellar tendon graft without gel, with gel at 6 months out. Something simple and cheap that Freddie Fu did a lot when I was in Pittsburgh was he just did a blood clot, just sewed a blood clot in. He was doing double bundle ACLs and sewed a blood clot in and MRI'd them at 6 months out. And these are some of the MRIs that he shared with me. We know that early accelerated rehab with a quick recovery of mobility, strength, and return to sport appears to be safe. There's no real evidence on intervention or timing of return to sport. Again, there are so many variables to consider, and we need more research. There's no standardized return to play guidelines that are currently set. Everyone's got their own. We know the functional training progression, we have to consider the timing, the type of graft we're using, the knee function as far as range of motion, laxity, swelling, strength, and then functional test results. The basic progression is going to be running, low agility drills, jumping, cutting, and then return to sports. Here's an example of you know, a typical kind of return to sport test potentially. We call this the pro agility test. Just something simple like that. Could you do it in your office or in your PT? The issue here is, this is a kid, I just wanted to show you an example. You know, the problem is this kid came to me and he had a revision ACL reconstruction. It was his second revision actually. Came to me for that surgery, and then here he is at 6 months out. And his post-op appointment, he brought this video to me and just said, "Hey doc, this is me, you know, when can I play?" So now he's 6 months out from his now third ACL.
Why don't you do one more?
So the problem with that is what do you do? You know, again, like we said, at 6 months out, we know the risk of a re-injury is high, but this kid feels great. He's obviously a great athlete. And so what do we tell these kids? How do we keep them back from getting back to play? And so we look at return to sport criteria. What do we use to assess an athlete? You know, performance-based testing to assess muscle strength, neuromuscular control, limb confidence, and the ability to tolerate sports-related loads. And if you look at the literature, so in our office, we can do a series of tests. And the literature supports the crossover and the 6-meter time test as the strongest predictors for self-reported knee function at 6 months and 12 months after an ACL reconstruction. The score is associated with the increased confidence levels, but it's not linked to return to play. And there's no predictive, it's not predictive of further injury. So now, do these standardized functional tests that we do identify limb deficits? We know that single limb tasks can identify significant residual deficits, like the ones we just showed, the triple hop and crossover hop following an ACL reconstruction. But if we try and modify tests, like modify our double limb tests, we find that they're not able to isolate out these single limb deficits. So we should really focus on single limb tasks when testing functional return to play. There's been a lot more data looking at now the neurocognitive aspect on the rehabilitation side. This was a study looking at brain activation for knee motion, and it's altered following ACL reconstruction. They looked at comparing fMRI data from controls versus ACL patients, and they found that following an ACL reconstruction, the brain activation profile indicates a shift towards a visual motor strategy as opposed to a sensory motor. So really rely on their visual motor aspect. Recent studies have also done looking at the disturbance in neurocognitive function that occurs after an ACL reconstruction or an ACL injury, similar to what we see in the following concussion. These disturbances can lead to an increased rate of lower extremity injuries. And these neurocognitive deficits include concentration, memory, reaction time, attention span, and processing speed. So what do we do? Again, these studies are looking now at VOMS, vestibular ocular motor system, and how do we start to incorporate that on the return to play following an ACL reconstruction? So what we actually started to incorporate here is we started incorporating some vision training, visual reaction time, peripheral range, recognition, accuracy, speed, smoothness of eye movements, and perturbation training, which is that unconscious reaction on unstable surfaces. We look at return to play now. We know that 70% of ACL injuries occur non-contact, and they're the basis of ACL prevention programs. And they focus on these neuromuscular deficits, which we'll go over in the next couple slides. We know that females are 4 to 10 times more likely to sustain an ACL tear than their male counterparts. Since the Title IX Act in 1974, female participation in athletics has increased dramatically, 5-fold at the collegiate level and 10-fold at the high school level, thereby giving us a lot more business on as far as ACL reconstructions. This data is really old. This is from 1995, but it's interesting to look, and this is looking at the Big Ten, Pac-10, ACC, and combined data at this time in 1995. And what they found, looking at the prevalence of ACL injuries, the combined data was about 2% for men and 16% for women. So these ACL programs, you know, they look at non-modifiable and modifiable risks. So the non-modifiable risks that females have are anatomic, notch stenosis, ligamentous laxity, increased lateral tibial slope, developmental changes. We know that boys undergo a neuromuscular spurt earlier than girls do. And hormonal changes, ACL estrogen receptors are present, and there's a higher risk for ACL tears during the pre-ovulatory phase of the menses. Modifiable risks, though, include the neuromuscular deficits, ligamentous dominance, quadriceps dominance, leg dominance, and trunk dominance. ACL preventions are really focused on the modifiable risk factors, and there are lots of different ones out there. There's the PEP program, sports metrics, and they all appear to be effective. They've been shown to have a 20 to 80% reduction in ACL tears. In this systematic review in JBJS, there was a risk reduction of 52% in female athletes and 85% in male athletes who followed an ACL prevention program. Let's go over these modifiable risk factors. Ligament dominance is when the supporting musculature does not adequately contract. So force is more force is imparted on bone, cartilage, and ligaments. And this can lead to knee valgus collapse and high ground reaction forces. Then there's quadriceps dominance. Women preferentially activate their quadriceps over their hamstrings, which leads to more ACL strain and a stiff-legged extended landing position. Leg dominance, women typically show a side-to-side flexibility, coordination, and muscular asymmetry. Trunk dominance, so during landing, deceleration, and pivoting, females' trunk motion is typically shown to be excessive and directed by inertia. So again, typically more of a weaker core, and this can lead to higher knee abduction moments and ground reaction forces. So again, these ACL prevention programs focus on these modifiable risk factors. They're strengthening, stretching, plyometrics. They focus on education, verbal feedback, and they should be done in the literature between 10 to 20 minutes 3 times a week. They can be incorporated right into practice and warm-ups. So I just wanted to share a little data from the NFL. I sit on the NFL executive board, and then I also sit on this lower extremity task force, which the NFL established 2 years ago to look at our NFL injuries. The NFL last year lost over $500 million on injuries alone, and over 60% of them are lower extremity. So when we look at the data, it's interesting, and we can look at the injury burden. So ACL tears, even though there were 193 in this group, we can see this over a period of 2 years. It was the longest injury burden time because the players are missing a year. But if we look at now, lower extremity injuries are second in line, and these are almost all hamstring and adductor injuries. So it's a pretty significant money loss for the NFL. And we look at now all the injuries and when the injuries occur. This is again looking at ACL injuries as well as the hamstring and adductor injuries. And this is for our off-season training. And what we're trying to do is decrease this rate and trying to figure out how do we decrease this. So we're doing all kinds of things, again, focusing on strengthening, flexibility. We're doing GPS monitoring. We are measuring hydration, sodium concentration during practice. So we're doing a lot of things to figure out why these are happening. And if you look at training camp, during this acclimation period, you see this kind of quick 3-day acclimation that we see some injuries, but then all of a sudden you get this big spike in that first 10 days of training camp. And this is when we see all the ACL injuries, all the hamstring injuries. The other key thing that has been much more commonly looked at and also in the literature is a psychological response is key. We know that we should assess psychological readiness. The fear of re-injury is a main reason that athletes don't return to sport. We know the internal locus of control is best. So people who believe they can make things better or make things happen to themselves. People have the external locus of control. Things happen to them. They do not do well typically and have a poor psychological response. Recovery expectations at pre-op and at 4 months post-op significantly correlate with outcomes following an ACL reconstruction. Positive responses are associated with return to play at 1 year after surgery. There are 3 main factors. There's this fear avoidance we want to talk to athletes about, pain catastrophizing, or so the people with low pain tolerance, and then the psychological resilience, how resilient are they to injury? So that fear of play or the fear of movement is common. And when studied, it shows that this kinesiophobia can lead to higher hamstring fatigue, worse triple hop and crossover hop, lower Kuss ADL scores, higher re-tear risk. And testing can be done with multiple things, the Tampa scale, the return to sport after injury scale, and the injury psychological readiness scale. So the Tampa score, if you look at this, is the scores range from 11 to 44. A score over 17 indicates high fear. So in this study that was published in 2018, patients with a score of over 19 at the time of return to sport were 13 times more likely to suffer a second ACL injury within 24 months. And patients with a score of over 17 at return to sport were 4 times more likely to report lower levels of activity, 7 times more likely to have a hop limb symmetry of less than 95%, and 6 times more likely to have quad symmetry less than 90%. This is the ACL RSI score. Hewitt published this last year, and looking at a score of under 77 points at 12 months post-op indicates that a patient who's under 20 years old has a much higher risk of a second ACL reconstruction. So this indicates that there may be benefit from additional psychological counseling before return to sport. How do we measure success? This was a study out of Orthopedics Today. It was old, from 2011, but it's funny. So orthopedic surgeons view our success as subjective. If our patient gets back to play, then they're good. Patient comes in, I feel good, doc, I'm playing. Then to us, that's a great outcome. But really, should we start looking at objective measurements? Should we look at them getting a 3D CT scan or a 3 Tesla MRI, biomarkers, and seeing, are we helping to improve their knee function, long-term longevity of their knee, decreasing the risk of osteoarthritis. Something else that is talked about and some surgeons are doing are looking at graft healing on MRI, assessing it before return to play. And we can assess this by looking at graft vascularity and that signal to noise quotient. So in summary, we know that autograft is really the best choice, but this should be based on personalized approach as well as risks. Aggressive, safe rehab is key. A team approach is really how I like to view it. I always tell the patient, my role is tiny. It takes me, whatever, an hour and a half to do your ACL reconstruction, but your part is much bigger than my part. And involving the athletic trainers, a physical therapist, a sports psychologist is needed. That's the key. I mean, that's what's going to make them successful. We focus on functional testing and really did a single limb focus and not doing both limbs, and focusing on the vestibular ocular motor system. Sports psychology, you should assess this early. Again, assess it pre-op as well as 4 months post-op. And if there's a concern, then get a sports psychologist involved early on. This will help the athlete return to play. ACL prevention is key, and we incorporate a lot of the ACL prevention exercises into our return to play functional programming. And then the other question is, do we look at MRI? What is that? Does that really help us or change anything? If you're going to release somebody back at 9 months, a year out, and you get an MRI and it doesn't show it's healed, are you going to make a change? Is that something that we should consider? This is some food for thought. Thank you.
Thanks, Robin. That was awesome. Any questions from the crowd?
I don't know. This is Dave again. I don't know if Joe Hart's on or not, but he may be able to share some of what we've learned through having what we've, really pretty good database now with trying to make return to play decisions. We have patients go through a battery of tests, and I think what you alluded to, Robin, is that the rush to return patients to play may have been a disservice. There was a point in time in my practice where patients were picking their doctors based on who would release them to sports quickest. They were shopping around. And now I think we're all becoming much more conservative, and we're learning that time is probably the most important predictor. But if you could, Robin, just walk us through your decision-making for return to play. You've got a NFL football player, they've had their ACL reconstructed, and what is your decision-making process for return to play?
I think it's so different, depending on if is it a kid in my office or is it an NFL football player? It's much easier on the NFL side in a sense, because I go in telling them it's going to be a 9 to 12 month recovery, and typically it's going to happen in a year later they're going to be returning. So the timing's a little bit easier from that sense, because they can't really get back quicker than 9 months. Even if they tear it in their last game of the season, they're going to have 9 months to get back. But and I also work with a great team of athletic trainers and physical therapists, about all these people, strength and conditioning coaches. So that player is getting worked on. Literally, they leave the OR and they are having rehab that day. And you see them in a week out and you think that they never had their ACL done. So they make it pretty easy because they get such great care. But again, at that point, let's say it's 9 months out, if everything, again, we've been following them so closely. So I'm relying a lot on the strength and conditioning coaches, athletic trainers to tell me, hey, listen, he looks great. He's passed all this stuff. And that's an easy decision. For me, the hardest part is honestly the high school kid who comes in. The high school kid comes in, and in my office, they look great. We have PT in our office too, so I can run down and watch them in physical therapy. But I rely on the physical therapist's eyes, our strength and conditioning coach's eyes downstairs to help me also make that decision. But in the office, I'm looking obviously at range of motion, swelling, how they are symptomatically. I might do some very simple functional stuff in my office, single leg squat, just some very simple things, just eyeball them in my office before having them pass our functional testing. It's probably like you have. I have a series of 5 tests basically that they go through. They've got to pass test 1 to go to test 2, and they'll bring me their check sheet once they're done. And once they bring me that sheet, then I release them. But I think that's the hardest part. And again, these kids, insurance covers 20 visits for a lot of the insurance companies. So, I try and help them spread that out. And are the kids who are uninsured and they come back, and how do you release them? And when do you know? And I try and, again, communicate with the athletic trainer in their high schools and try and keep that communication open. I think that's key to their success. I don't know how you guys, what do you do in your office, just you alone?
Similar. We actually send them for testing. We call it LEAP testing. The first step we do now at 4 months. We found if we waited to 6 months to do the first testing, we missed an opportunity to motivate. So at 4 months, they come back with a set of numbers, and we review that with them and help to motivate them for the next phase of rehab. There you go, Winston, that's exactly it. So you're gonna have isokinetic, isometric strength testing, and then functional tests like vertical hop testing, leg hop, jump landing, and then there'll be comments based on their mechanics as they land with valgus posture, etc. And, you know, green light, red light type thing in terms of your scores. But we've looked at, is it a matter of strength on the ipsilateral leg? Is it a matter of symmetry? You know, which is more important? And it's been hard to get a handle on that. It seems to be more recovery of strength is more important than symmetry, which was counter to what we may have thought. And of course, good mechanics. So at 4 months, we'll go over this with them. Then at 6 months, they'll come back again, but almost nobody reaches the green lights across the board at 6 months. I mean, I can't remember the last person that did. And so we're really using this to kind of motivate and kind of give them targets to continue working, and then they'll come back at 2 month intervals. We found that it takes 2 months between testing to make a measurable difference that matters. So that's been helpful because they always want to just, let me test again next week, you know?
Yeah.
So at 8 months, then they'll come back, or we'll do this by email. And usually that's the point in time when they're really starting to get ready for release. Nobody still makes it across the board, but if you're getting close and things are going well, their knee isn't infusing or showing irritability, then we'll probably think about releasing them at 8 to 9 months, which is a big change for us. And what I just heard from your answer is you're really looking at 9 months minimum, it sounds like, in most cases, which is a big change for orthopedics.
Yeah, it is. It's hard to convince the patients, like you said. They're always looking for the fastest. And
yeah.
Is
Joe on?
So are all patients getting this? Like even let's say your high school athlete, everyone's going to get this? Do they have to pay out of pocket for it? Or how does this work?
Joe Hart's on the call. I think you can answer that question for us.
Hey, Joe.
Hey, Robin, how are you?
How are you?
Good. Yeah, no, it's part of a research study that we've been doing for the last 6 years. So we do it out of our lab in the Department of Kinesiology, Exercise and Sport Injury Lab. So it's free now as a part of a research study. But we're seeing everyone at 4 for like a quick kind of non-weight bearing quad and hamstring test is to establish kind of a baseline. We see them back at 6 months and then again at 8 months. You know, the 4 and 6 month evaluations are fairly routine now, and we add jump testing and movement quality testing and a whole battery of PROs that you've listed on in your talk that we kind of present some of them in this report that we give to the surgeons. But we've been inviting people back annually, because it's kind of like a major surgery like an ACLR reconstruction. You kind of would expect long-term changes in muscle function that you want to be able to identify as you're going along. We see a lot of folks back before they return to sports season in college here at UVA. Kids will come back and see us over the summer quite a bit to have a strength checkup to kind of dictate the next steps in their rehab and their care.
That's great.
So free has been essential.
Comment, we've come a long way from accelerated rehabilitation.
Yeah.
So I think there's some questions from the audience. Michelle Q, do you want to unmute yourself and ask your question?
Yes, I asked questions about return to play. So do you test all your patients for fear of return to play? And if you do, how do they respond when they get the results that they have some concerns or have some fear that they didn't really know about returning to play on their reconstructed ACL?
I don't test everybody. I identify the ones that I'm concerned about. And the ones that I'm concerned about, then I'll send to our sports psychologist. So I don't test everyone, Michelle. I would like to, and that's my plan to start that this year, actually, to have every ACL reconstruction done in our practice tested. But I'm not doing that right now. I'm just identifying just from some simple questions. Again, you can usually tell pre-op, but then at that 4 month mark.
And then do you know
a lot of the professional, I'm sorry, a lot of the professional guys even need it. And I send a lot of them to our sports psychologists because it's a huge, huge loss for them. And you know, and they all say, well, I'm a mental fortress, I don't need anything. And so they kind of poo-poo it, and then they see our sports psychologists and they're like, oh, doc, she really helped me tremendously. So I get them involved if I have any concerns too. But go ahead, Michelle.
Just a second question. Do you know of any youth leagues or any high schools, colleges that actually institute the neuromuscular preventative training? I know we talk about it a lot in literature and we know it's very important, but does anyone actually implement it to help prevent these injuries?
No, that was kind of my first thing when I got here, to try and push it out to the high schools, and everyone says it's a waste of time, it's too expensive, and even if you try and I had our strength and conditioning coaches go out and just teach the coaches, hey, just incorporate it into your practice or, you know, into your warm up, but I don't know anyone who's doing it.
I got a couple questions off the from the group. From Dr. Dacus, how do you manage quad atrophy after ACL reconstruction?
I actually do a lot of quad tendons and BTB, so I do see quad atrophy. You know, I started therapy right away, so I usually have the patients seeing the therapist, you know, day 1 or day 2. I'm on them. That's my first thing, to get them that hyperextension. I educate them all pre-op and tell them that's your first thing you have to do. I want you to have a straight leg raise that week 1 when I see you. I want you to have full extension, and get them to really, it's education, I think.
And then from Dr. Matt Deasy, Dr. Miller often talks about patients about whether they trust their knee when they assess ACL injuries and recovery. Could some of the association between anxiety and fear and re-tear be an adaptive response to subtle instability?
Yes, I 100% think so. You know, that's what you have to tease out, right? I unfortunately here do a lot of revision ACLs. I see a lot from the community, and again, they're not gross failures, but they're people who come in and they have a sense, I had never got back, and I was a college athlete, and so you have to figure out, are they just nervous to get back, or what's going on? And you get an MRI, tunnel placement's a little bit off, their knee's a little unstable. So is it really they're just feeling that sense of instability, or is there a sense of fear?
Exactly.
But I think that minor sense of instability, again, I've seen a lot of poorly done ACLs, and people are playing at the NFL Combine. You look at these guys come through and their ACLs are horrible, and they play. Now it's a combination, they're a great athlete, but they also do have that mental fortitude. And so I think that when you talk to them, they don't ever have instability. They are admitting to it. I do think that some of that mental fortitude can help also, even if the outcome is not perfect.
And then from one of our other residents, Richard Campbell, not sure if it's a good question or not, but what percentage of failure would you attribute to post-op rehab adherence? And is a significant decreasing failure going to come from further surgical advancement or improved post-op protocols?
Yeah, I think obviously, I think we've all seen the surgical techniques have dramatically improved over even the past 10 years. So I think that we're learning more and more, and the techniques improving. So the question is, do I think that rehab plays a huge role?
I guess the question is, do you think that decreasing failure rates going forward is going to come from being better surgeons or better rehabbers?
I think a combination of both. I do. I think that, again, every athlete's different, and depending on do they start off to be a great athlete, or that's going to improve their outcome. But I think that the combination of technique and rehabilitation is going to be key.
Great. Any other questions from the audience?
Great.
Really great talk.
Looks like Dr. Dudek just unmuted himself. You have a question, Dr. Dudek? Or?
No, I was just going to say thank you. I think Bobby's going to do the same.
Awesome. Well, I'll close up at least the moderation part of the talk. Dr. West, that was fantastic. My phone is blowing up with people saying the best grand rounds ever. So we got to figure out some way to get you down here to spend some more time with us and share your wisdom and your insight with our faculty and residents. So with that, I'm going to turn this over to Dr. Chabra and let us close this out. Thanks.
Thank you. Thanks so much for having me. It was great. You guys put a great case presentation together last night, and it was terrific.
Thanks again, Robin. Truly remarkable. Thank you for your honesty and transparency about your life and your struggles and successes and difficulties. I think it was incredible for our residents and fellows, faculty, and team members to hear. You're obviously a remarkable leader, a remarkable mentor. and very fortunate that we have a relationship with you between UVA Orthopedics and Inova Sports, and I hope that this continues to grow and strengthen and the bond becomes even stronger. So we would love to have you here in person in the future, and I truly appreciate you taking time. I know you've probably got to rush off right away to go take care of all these issues now with the Nationals and the Washington football team. And, you know, I'm a diehard, grew up in the DC area, diehard DC fan. I need you to help fix the Redskins. I'm tired of driving back and forth every weekend for the football team.
It's not the Redskins.
Sorry, for the football team, but we got to start playing better on the field. Otherwise, it's making it harder and harder for me to drive 3 hours back and forth every Sunday. So.
That's true. I think Ron's making some big changes. So
yeah, excited about that. So, but thank you again, and hope to see you in person very soon. And again, it's very much appreciated you taking the time last night and today.
Thank you so much for having me.
Virtual round of applause.
Yeah, feel free if anyone has if the residents have any questions or anything, they can email me or I can give my cell phone out. Fine with that.
Be careful what you ask for. You might get a lot of emails.
That's fine.
Awesome.
All right. Thanks, guys.
All right. Well, see everybody next time. Thank you so much.
Okay. Thanks.
Thanks, Robin.